This is Dr. Carlo Ogier, board-certified emergency physician with DrER.TV. And if you're watching this video, you are actually at ED Video Pro, the channel where we specifically target our healthcare enthusiasts, medical students, nurses, pre-meds, and other physicians who just wants to review cases and learn more and keep astute in their clinical practice. This case is about a 36-year-old woman who awoke with acute visual loss in her right eye. The lesion developed overnight. History was significant for photophobia. That means she had fear of light, but it's really painful. It hurts for the light to shine in her eye. She had upper respiratory infection with right eye discharge and a remote fingernail scratch on the right eye. Remote, what does that mean? A day, 2 days, a week? I don't know. On physical examination, the right eye visual acuity was to hand movement. That means that when we do a visual acuity, we put the patient to the classical kind of letters on the board and we have them read it. The big line is so much. The second line gets smaller, smaller, smaller until we get to 20/20 or 25/20, even when they have eagle vision and they can see a lot more. However, when the patient can't even read the first line, then we use hand gestures like how many fingers can you count? 1, 2, 3. So that's when they mean what visual acuity is to fingers, means she can count. To movement only, we move the hand in front of the eye. Can you see a movement on a hand? And they might say yes. Or they might be to light only. So that means that we shine a light in their eye or not, and if they can see that. So when you cannot measure the visual acuity on the Snellen eye chart, then you do finger counting, you do movement, and if not, you do light vision. So when you're expressing or telling somebody else about the patient, she has vision to fingers in front of her, she has vision to movement only, or she has vision to light and darkness. On physical examination, the right eye visual acuity was to hand movement only. We said that. The left eye was unaffected, and a bulging cornea protruded through her eyelid on lid closure. That means the eyelid couldn't close all the way, and you can see part of the cornea coming out of it. Slit lamp. Slit lamp is a special machine, almost like a macroscope for the eye. Usually has hospitals that have this kind of equipment. Most do, but sometimes they preserve it. It's not in the emergency department and stuff. It's maybe in the operating room. But obviously, eye doctors have this kind of equipment. The slit lamp examination revealed corneal edema, clouding, which means just what the word suggests, clouding is like that thickening, like you can't see through, and no fluorescein intake. Fluorescein is a dye that is placed on the eye to reveal the presence of a break in the superficial layers of the eye. When it acts with the basement membrane of the eye, it produces a different light color when it's lighted up with UV light. So when we do fluorescein staining, we can see scratches in the eye that would be naked to the eye. Emergency ophthalmology consultation led to prompt diagnosis. So we called somebody who knows what they're doing, and we came up with the diagnosis. Let's look at that eye. Obviously not good looking at all. You can still see that the conjunctiva is pretty white. I mean, it's got a little bit of hyperemia vessels. The conjunctiva, it's a little bit reddened, but you can see that the iris, the color part of the eye, is being clouded by this round, cloudy, milky lesion right in the middle. So this is where the abnormality lies. So now remember, the patient had a history of a remote scratch in the eye. She had upper respiratory infection and she had discharge before this occurred. That's very important to the history. So what is the diagnosis? Patient has keratoconus with acute corneal hydrops. Keratoconus is a non-inflammatory disorder of the cornea characterized by progressive thinning and bulging, otherwise known as ectasia of the cornea. Acute corneal hydrops is a rare complication of keratoconus, occurring in less than 5% of cases. Acute rupture of Descemet's membrane, we mentioned that we were talking about fluorescein staining, Descemet's membrane, results in fluid accumulation in the corneal stroma, stromal and epithelial edema, and acute clouding with decrease in vision. The pathogenesis of keratoconus is unclear and likely multifactorial. Most cases occur spontaneously, but there is an association with systemic and genetic conditions, including atopy, Down syndrome, connective tissue disorders, trauma, ulcers, eye rubbing, and contact lens wearing are also implicated. The acute corneal hydrops treatment focuses on patient comfort. This is an extremely painful condition and may include hyperosmotic agents, topical corticosteroids, and prophylactic antibiotics. Psychoplegics are medicines that basically stun the iris from contracting in response to light, and anti-glaucoma medications to reduce the internal pressure of the eye may also be used for pain relief and prophylaxis. Edema resolves slowly during 2 to 4 months, irrespective of treatment. Subsequent corneal scarring or refractory edema may be treated with a corneal transplant. Our patient was treated with topical steroids and outpatient ophthalmology follow-up. So this is a rare disorder. I've never seen anything like this. Obviously, seeing something like that would require you to immediately get an eye consultation. I would have been highly suspicious of a corneal ulcer, but the diagnosis was not that because when you did the fluorescein stain, there was no optic. I thought this was going to be a complication of a corneal abrasion and then a corneal ulcer with causing an infection of the eye itself, but it was not. It was what is called keratoconus with acute corneal hydrops, corneal fluid. And again, remember that this is a non-inflammatory disease. It is the cornea that is mostly involved, and it's a rare complication. And what happens is there's a rupture of the membrane, the cement membrane of the eye, and it results in fluid accumulation in the cornea itself. Ultimately, probably leads to a corneal transplant need because of the healing and acute visual loss of this patient. Now, this is a good one. Certainly nothing I was ever exposed to during my career, so it's nice to review this case. So if you ever see something like this come up, you think that at least you should know there's some kind of fluid accumulation in the cornea, and if you figure that out, then you can kind of tell that the name suggests corneal hydrops, and then you think of that weird word that we're going to learn just now, keratoconus, or if it's pronounced differently, please forgive me. And that's it for today. Hope you learned something with this video. I hope you're learning with a whole series of videos, and that you subscribe, you share, and you send me more people over, medical students, nursing students. This stuff is good stuff that we need to learn and be aware of and keep reviewing and learning so we can become better clinicians and hopefully help more people. So stay tuned for our next clinical video. We'll see you later. Bye-bye.